So thank you for the invitation. That's just title slide, and this is the usual disclosures, which are not very exciting. The reference to thousands of papers is a gross exaggeration, I'm afraid. You can probably count them on about 4 hands, but there we go. So, what do we call ourselves, first of all? Even we aren't entirely sure what abbreviation we want to use for these tests. NCS for nerve conduction studies. NCS and EMG is actually accurate, but it's clumsy, so it's often shortened to just EMG. And then patients look at it and conclude that they're coming for a needle exam and are puzzled when we don't stick any needles in them. One lady actually sent me a formal complaint for doing that once. The Americans like the term electrodiagnosis, which has some advantages, but it hasn't really taken off on this side of the Atlantic. So this is what it's about, and this is what we do. That pointer does mirror. So if we stimulate the nerve in the finger here with these ring electrodes, with a little electric shock, and put a recording electrode over the median nerve at the wrist, we can record sensory nerve action potentials. We know they're sensory because we're only stimulating the sensory fibers in the finger, even though we're recording over a mixed nerve. Conversely, we can go the other way around. We can put the recording electrode over APB, which you can't see very well here, and we can actually stimulate the mixed nerve and produce a twitch. And again, that has an electrical equivalent. And this time we know that we're selectively recording motor function because we're recording from a muscle. And of course, the patient can feel the stimulus because we're stimulating sensory fibers as well. We just aren't recording anything that's related to the function of those sensory fibers. So that's broadly what you're sending your patients for. You should all go and have your own nerve conduction studies done if you haven't done them already. So, now we're going to try and be adventurous. This is the sort of result you get. And in the top right corner, you will see there is a QR code. If you point your phone at that QR code, and I'll give you a minute or two to go and grab your phones from wherever you've left them, and click that, you will find you're presented with a question to answer. And I think we had about 80 odd participants, I think, didn't we? So let's see how many come in. I've got 4 responses there. I presume there are several people scrabbling around, wonder whether they put their phones down. The question here for anybody who is not participating is, I feel confident in interpreting electrodiagnostic recordings for myself. Yes, no, or sometimes when they're simple are the 3 options. I've got 27 responses. We're doing quite well. It's at this point that the story could have come to a very abrupt halt, because if everybody said yes, I was just going to stop. Got 33 responses. Come on, a few more people, go and find your phones. I'm going to do this about 5 times in the course of the talk. So, and this one, of course, is the easy practice question. 34, we've ground to a halt. I think anybody else is being very slow. So, rather gratifyingly, not a single person has declared that they're confident in interpreting these things. So perhaps there is good reason for talking tonight. They're not always as straightforward to interpret as you might think. These physiological signals that we're looking at here are influenced by a multitude of other factors. The machine and the electrode types that you use, the race of the patient, and particular methods for applying things used by that laboratory, or even the individual technician, will all have an impact on these. So laboratories have their own normal ranges. So if you're going to interpret these, you actually need to know what your laboratory's idea of normal is. And a good example of just how much difference you can get is this. This is how nerve conduction velocity changes with the temperature of the limb you're testing. And this is quite a profound effect. You can see the sensory conduction here varying from about 40 to 60 meters per second over a temperature range. These are 1 degree C divisions, or these are 2 degree C divisions. So it's around about 2 meters per second per degree centigrade change in temperature. And if you don't know what temperature the hand was at when you were doing this recording, then this can easily shift a result from within a normal range to an abnormal range if it was cold. So you're probably wise to read the comments at the bottom of the report and rely on the lab to warn you about things like a hand recorded at 28 degrees C this morning on a rather chilly, wet day in Canterbury. So I'll try to briefly explain how these physiological measurements relate to pathology. 3 pathological processes occurring in nerve affect these measurements. First of all, demyelination. This occurs in a variety of disorders, but this is a patient with a left ulnar nerve lesion at the elbow. You will remember that myelination of large fibers allows saltatory conduction and a faster conduction velocity. So loss of the myelin slows conduction in myelinated fibers. Here we can see motor conduction in the normal ulnar nerve in green. The nerve is stimulated at the wrist, below the elbow and above the elbow. So we've got 3 recordings. And the horizontal axis is the time from the stimulus. So the difference in timing between these two is the time taken to travel down the forearm, and the difference in timing between these two is the time to travel around the elbow. This is the normal side, and you can see the recording on the other side, which is the symptomatic side here, is very different. And there is a drastic time difference between the below and above elbow recordings, so that the conduction velocity in the forearm is 60 meters per second like the normal side, but around the elbow we're down to only 20 meters per second. So there's some severe demyelination in that elbow segment. Secondly, there's the phenomenon of conduction block, which is a bit more obscure. Notice that the vertical scale of the abnormal side here is different. This is 2 millivolts per centimeter vertically. This is 5 millivolts per centimeter vertically. So this recording at the top is actually something like 7-8 millivolts. This one is 3 millivolts. But when we go above the elbow, it shrinks down to only 1 millivolt. What this is telling you is that some of the action potentials triggered when we stimulate above the elbow aren't propagating past the elbow and on down the forearm. That is conduction block. Thirdly, axons may be completely interrupted. This also causes loss of amplitude of the signal. But in this case, it doesn't vary depending on where the stimulus is applied. So here we can compare with the normal side and see that even when we stimulate at the wrist, the signal is much smaller on the affected side, 7 millivolts on the normal side, 3 millivolts on the affected side. So we've actually lost some axons here as well. As well as measuring the properties of nerve, we can also use needle EMG to examine the electrical signals generated by muscle cells in more detail. And again, there are 3 processes affecting the findings. First of all, volition. Normal muscle produces no electrical signal at rest, and only when the patient attempts to contract it or we stimulate the nerve electrically do we actually see anything coming from the end of the needle. Secondly, denervation. Denervated muscle becomes hyperexcitable, and this is seen as abnormal spontaneous activity on needle EMG. And I don't know whether this will work. We're off Zoom, but it's worth a try. These are fibrillation potentials and are a sign of denervation in a non-active muscle. The patient isn't trying to do anything with this. Oops, got back one. Finally, although you'll rarely encounter this in hand surgery, in myopathy, the muscle cells themselves are abnormal, and this can produce a variety of effects on the EMG signal, including abnormal spontaneous activity like that in inflammatory myopathies. It should be noted that the results of EMG are in general more qualitative opinions expressed by the examiner based on pattern recognition, rather than quantitative measurements, unlike the nerve conduction studies. So how do we use this to help with clinical problems? So firstly, I'm going to talk about trauma. In the circumstances of an acute nerve injury, what do we want to know? The questions aren't the same in every case, of course, but usually it boils down to some combination of where is the injury, what sort of injury is it, and how severe or complete is it? The changes in nerve and muscle function as a result of injury have a well-known temporal pattern, and the commonest failing of communication between surgeons and neurophysiologists relates to timing. The key point is that before 2 to 4 weeks from the event, it's impossible to distinguish a lesion in which the axons have been severed from one in which they're still in continuity, because this depends on us detecting fibrillation potentials in denervated muscle. And as you can see from this little time course, they actually take a few weeks to develop after an acute nerve injury. If you're lucky enough to be able to see the nerve on ultrasound imaging during this period, that can be very useful, however. So if you've got somebody who's interested in ultrasound, it's worth talking to them about that. Compression and stretch injuries, however, show local nerve swelling regardless of whether there's axonal loss. So in a lesion that is physically in continuity, we actually need the nerve conduction studies to tell us something about the state of the axons. There's thus a critical time window. We need to be long enough after the event for some changes to have appeared, but they will actually disappear again a few months later. So sending me a patient 2 years after an injury and asking me to tell you very much about it probably won't tell you much more than you could by looking at the patient. So let's have a look and illustrate this with a case. This lady had a fairly minor bit of knee surgery on a Thursday, but woke up with a foot drop. Our surgeon called me on Friday and we saw her on Monday. So this is 4 days post-event. Even though at this point she had a flaccid foot drop with no ability to voluntarily dorsiflex the ankle or toes, it was still possible to elicit these movements by stimulating the fibular nerve at the ankle or at the fibular head. And the bottom set of traces here are those recordings from the ankle and the fibular head. However, when we try to stimulate proximal to the surgery site in the popliteal fossa, there is effectively no distal twitch, virtually complete conduction block. At this point, we've confirmed what we could have guessed anyway, that the lesion is at or near the operation site, and we have a strong suspicion that there has been some axonal interruption because this signal is noticeably smaller than the one from the normal side. We then get the ultrasound scanner out, and here is the fibular nerve coming from proximal to distal, and you can see the nerve fairly clearly along here, and then something happens there, which is not quite right before it reappears again here. So we see one side of the epineurium, middle of the nerve, the other side of the epineurium, and something of a gap in proceedings. If I've not convinced you with that, we can play this on a little video. So now we've moved to a transverse view across the nerve. This is the fibular nerve, and we're proximal to the lesion. And if we scan down the nerve, you will see, I'll keep the cursor just underneath the nerve. We have nerve, nerve, no nerve, nerve. She duly went off to Stanmore, in fact, to have this explored. And what was found was that the nerve had been included within a suture, producing a tight ligature around it. This was divided to release it, and it was hoped that this would solve the problem. And she returned to me 6 months later, unfortunately, still with a foot drop. Come on. Let's go to the next slide, please. Thank you. So this is later on. The fibular nerve is now much closer to the surface. And you can see coming all the way across the image here, same orientation as previously. It's clearly normal here, but this whole segment is not normal. And in fact, the epineurium doesn't seem to be quite intact across here either. And again, if we play the video clip, we have the nerve here. And although we can see it through here, this whole segment is abnormal, large, hyperechoic, with an abnormal interior structure. So unfortunately, this didn't do very well. So here's another injury case. Now we're back in hand surgery territory. So this young man took a Stanley knife to his wrist, but his physiology is interesting. He has no recordable motor potential. Normal side, abnormal side. But rather bizarrely, he has got a small sensory potential from the median nerve. So we've got some functional sensory fibers, but no motor fibers. And again, here is the ultrasound. The median nerve is here. You can see several fascicles on a very high resolution scan. And as we come up through the lesion, there is a substantial neuroma, but there are two fascicles at the bottom here which continue all the way through it. I'll play that again so you can have another look at that. So, yeah, we are, I hope, yeah, distal to the lesion. These fascicles don't look quite normal downstream from the injury, but they are there. But these two here go right through the bottom and are presumably two sensory fascicles which are subserving that bit of function. And here's one more hand one. This lady went in for a gynecological procedure, and the anaesthetist put a butterfly in the back of the hand. When she came round from that, she noticed a little numb patch. It's just at the base of the middle and ring fingers on the dorsum. And that little black dot is the interesting structure here. So this is one of the end branches of the dorsal and cutaneous nerve. And if you watch the video as we scan down this little dot, you will see as we reach the injury, there's a little neuroma. I think that was a very unlucky anaesthetist. But with modern scanners, we can see some very small nerves. This one is around about 0.7 millimeters across. So that's all acute injuries. Most of the things we see, however, are this, rather more chronic or subacute nerve injuries. And there are some important principles here. Local demyelination tends to occur before you lose the axons in these things. You may or may not get conduction block. And most of these things can be confidently diagnosed from the clinical history a lot of the time. Finally, by the time reliable physical signs have appeared, it's often too late for the most effective treatment. And we're going to come back to that. So we're going to use my favorite topic of carpal tunnel syndrome to talk about this. And you're going to need your phones again. So here is a case to start with. This is a real case. It's not from the UK. Well, I'll give you a minute to read this. He's a relatively young man. He's got quite a long history of somewhat vague symptoms, but then develops what he himself describes as CTS-like symptoms. So he's got sensory disturbance in the median territory, a rather weak grip, hand fatigue and clumsiness. And he goes to see a surgeon and finds positive Tinels, but not very much else. So if you go for the QR code, you should find a two-part question. Give me a minute. I've got 28 responses so far. 30. Okay, so 35, 36, we're going to get to 40. 40 would be a good target, wouldn't it? 37. I think we're going to grind to a halt there. So 7 people are fairly confident this patient has developed carpal tunnel syndrome. 11 are equally confident that this is not carpal tunnel syndrome, and there are 19 maybes, which is probably reasonable in the circumstances. And you're obviously going to keep me in business, because 34 people have said, yes, we'd organise some nerve conduction studies. So some nerve conduction studies are done. And here's the report. So the neurophysiologist says this patient has got a right carpal tunnel syndrome affecting motor components, which is US shorthand for there is a more severe carpal tunnel syndrome. So now do we think the patient has got CTS? Have we shifted some of the maybes in favour or against? Now people are taking a bit longer to think. I can see some results coming in. It's 29. We had 37 a minute ago, so hopefully we'll get to about the same again. Six people have dropped their phones or have alternatively realised that I'm trying to lead you into a trap. So I've got 32 responses. The first interesting thing is that quite a lot of people have now changed their minds in favour of carpal tunnel syndrome. We've now got 22 to 10 saying yes or no to whether this is carpal tunnel syndrome. So I think there is some evidence there that the result is being used diagnostically and is influencing what people think about the case. Would you be brave enough to operate? Well, in fact, about half the audience would be willing to offer surgery for this chap. 16-16, exactly half and half split. So the patient went on to have a carpal tunnel decompression, and I'm afraid he's no better afterwards. And that's why I've heard about this case. He's not happy. He spent a small fortune on co-payments mandated by his insurers, as this is the USA, for tests and surgery, and his symptoms are no better. The surgeon's not happy either. He's got an aggrieved patient and he thinks the neurophysiologist got it wrong and misled him. And the neurophysiologist, I have to say, is completely oblivious because he hasn't seen the patient again and doesn't know what's gone on after issuing this report. So what went wrong? Well, essentially, the person who provided the neurophysiology report here was acting a bit like a computer algorithm and simply interpreting a set of results with not very much reference to the actual clinical presentation. They've also been conned into believing that there is such a thing as pure motor carpal tunnel syndrome, which doesn't actually exist. So we all suffer from elements of tunnel vision. Thinking that CTS is simple. The surgical view, it's an obvious diagnosis. The only effective treatment is surgery. Therefore, what do you do? If it's carpal tunnel syndrome, you operate on it. And then one of my heroes is Ben Goldacre, who used to write in The Guardian, but nowadays works for the Centre for Evidence-Based Medicine in Oxford. And he was going to have a T-shirt printed with this on as his motto, and it's well worth remembering. That patient has probably got thoracic outlet syndrome. So here's another question for you. Why do we carry out nerve conduction studies in carpal tunnel syndrome? And that one hasn't worked, has it? There you go. You've got another QR code to go for there. You can choose multiple answers on this one. We'll go through this fairly quickly because you've already seen my answer quickly, courtesy of PowerPoint. There are some interesting numbers in this, though. So we have roughly equal numbers of people going for the first three because it's expected for diagnostic purposes and for the detection of other problems. But we've actually got a majority in favour of to record a baseline for later comparison, which is interesting. I think these are actually the main reasons for carrying out nerve conduction studies. Not often for diagnosis, and hopefully not because it's expected. That's rather sad. You shouldn't be doing things because somebody else thinks you should do it. So, whenever we arrange an investigation in medicine, we should ideally have pretty clear ideas about why we're doing it and what we're going to do with the results. All too commonly, a nerve conduction study is viewed as a diagnostic test which has a binary outcome. Either the disorder in question is present or absent. And much criticism of these tests as being inaccurate stems from this false premise. I'd like you to encourage you to consider these as an extension of your normal clinical history taking and examination, which provide a quantitative measure of an aspect of patient physiology which you're unable to assess with your ordinary senses. You can't know a patient's creatinine clearance without doing some biochemistry, their bone mineral density without a DEXA scan, or their nerve conduction velocity without nerve conduction studies. So if we look at patients who are sent to my department with a request form which says query CTS, which is about all that ever gets written on a form, what do they look like? This graph is the distribution of prior probabilities of CTS. This is the probability that the patient has CTS before they walk through my door. You don't need to worry about where this comes from, but you can see that they fall quite neatly into three groups. Roughly a third clearly don't have carpal tunnel syndrome, despite what it says on the request form. Roughly a third might or might not have, like our previous patient. And roughly a third are quite clearly carpal tunnel syndrome. In this group, the question being asked is not whether they have CTS, but what do they have? And in about 7% of them, the tests reveal another neurological diagnosis. In quite a lot more, now that I've been running the Carpal clinic for a long time, I'm fairly sure that they have something that's not in my field. Trigger digits, the curve veins, all kinds of other things roll up as query CTS, and referrals come from general practice. But I wouldn't presume to be definitive about diagnosing those and put them in this slide. This group is where the test can influence the diagnosis one way or the other, as we saw with the result in the previous patient. But note that these are a minority, only 29% of all the referrals. And the third group are actually the ones that you usually see as surgeons. People don't come to hand surgery clinics unless they've exhausted all other possibilities on the whole, and they tend to be relatively obvious and more severe CTS. It's worth noting that 5% of these patients turn out to have another neurological problem as well as CTS. And that comes to light on the nerve conduction studies, but we'll return to that in a minute. The big question mark here is, what is the purpose of testing these people? So before I come back to that, let's tackle the diagnostic group. So this has also been criticised. This is Brent Graham from Toronto. And he accepts conventional figures for the sensitivity and specificity of nerve conduction studies when they're used in the diagnosis of CTS. But he thinks the test, however accurate or inaccurate, is simply unnecessary. This figure from one of his papers purports to show that the test doesn't significantly change the probability that the patient has CTS. This belief is founded upon the equation at the right-hand side. Anyone recognise that one? You can't shout out without a real audience. But this is Bayes' theorem. It tells you how to adjust your view of the probability of the disease being present in medical context based on the result of a test. And if we understand this fully, we can see why he's actually both right and wrong about this. So I'm going to inflict some evening mathematics on you. This is a complicated slide. I'm just going to get more complicated as we go on. This is Bayes' theorem again. Slightly different form of it, but you can trust me, it's the same thing. And this term is the probability, the conditional probability of A given observation B. So this is the result we're going to calculate. It's the probability of CTS given a positive test result, if we work it out this way around. This term is the probability of a positive test result given the fact that the patient has CTS. This one is the probability of CTS before we carry out any test. That's the prior probability. Now, this one here looks familiar, doesn't it? It's just the sensitivity of the test, the proportion of people with CTS who have an abnormal test result. So let's replace it with something a little bit more familiar. Now let's look at this rather complicated term at the bottom. This is the overall probability of a positive test result, and it's made up of two parts. First of all, note that the left side of it is exactly the same thing we've just seen on the top. So let's replace that. The right-hand side is a bit more complex, but these things too can be replaced with more familiar terms. This term is the probability of an abnormal result in a normal subject, which is actually just 1 minus the specificity of the test. And finally, as we're dividing the population into two mutually exclusive parts, CTS and not CTS, this term, the prior probability of not CTS, is just 1 minus the prior probability of CTS. Note that if the prior probability of CTS is 1, i.e. we're 100% certain the patient has CTS, then the bottom right term becomes 0. And the result, the probability of CTS, becomes 1, regardless of the diagnostic properties of our test. Or to put it in plain English, if we already know the diagnosis is CTS, then the test result makes no difference. And that is essentially Brent Graham's point. Note, however, a very important thing. This term PA appears in 3 places in a small equation. there. The results of this calculation depend heavily on context. And in this case, the context is the prior probability of CTS. If that's close to 0 or 1, then Brent's absolutely right. But if it's 0.5, then he's wrong. And the properties of the test do make a diagnostic difference. And the higher the sensitivity and specificity of the test are, the bigger their difference is. So for a patient in which there is clinical equipoise and a 50% probability of CTS, and if you use fairly reasonable figures for the sensitivity and specificity of the test, then a positive result is going to change the probability of CTS to about 90% and a negative result to about 10%. So in that middle territory, there is genuine diagnostic value in the test, but it depends on how sure you are of the diagnosis to start off with. So what about this mysterious figure of prior probability? How do we know? The most basic figure we could use is the prevalence of CTS in the population, which is a good starting point. People are forever telling me that this is a clinical diagnosis, by which the average surgeon means that CTS is what I say it is. However, we know from many studies that clinical diagnosis is not infallible, and I would recommend this review. The more thoughtful surgeons do recognise that there are some cases in which they're not sure of the diagnosis and where the test may be useful for diagnostic assistance. But working out the prior probability in such circumstances is very difficult. Human beings are very poor at accurately quantifying their level of uncertainty. What we need is an artificial intelligence clever enough to tell me the prior probability of CTS. Fortunately, there is one. Patients can complete a symptom questionnaire on my website and it will estimate how likely they are to have CTS. And that's where the distribution of probabilities in the earlier slide came from. Now, what about those patients who obviously have CTS? The patient and the doctor have to make a decision about how to treat it. If you believe that all patients with CTS require surgery, then this is pretty straightforward, and you just have to accept the complication rate of surgery as the price of benefit for the majority. However, most published guidelines do accept that non-surgical treatments have something to offer. So there are choices for patients in this situation, and what is the patient supposed to do? The balance of possible risks and benefits is complicated, and most patients need help. This is broadly how I tend to present the issues to patients who I'm advising myself. The only evidence-based treatments are splinting or do nothing, local corticosteroid injection and surgery. And essentially they are more effective as you go from left to right, but also have a higher complication rate as you go from left to right. And of course, the difference between injection and surgery is very much in terms of duration. And of course, there's no shortage of advice for patients, most of which boils down to treat severe cases surgically and mild ones non-surgically. But most such advice is rather haphazard about how to define severity. We can all agree that this hand on the right here is severe, but such cases do relatively poorly with treatment, and we really need to deal with them before they reach this stage. It turns out that there is a fairly systematic approach to choosing a treatment proposed by European hand surgeons and therapists. And this rather fancy diagram invites us to assess patients on two axes: the duration of symptoms up the vertical axis and the subjective severity of symptoms, using whichever tool you wish to use for that across the horizontal axis. The assumption behind this, of course, is that more severe disease requires more aggressive treatment, because severe disease is less likely to respond to the milder options and delay is dangerous. i.e., they're really suggesting that these two indicators are predictive of outcome. Unfortunately, they aren't. On the left side here, you can see the success rate of surgery in relation to how long symptoms have been present before the operation is performed, and it makes absolutely no difference. Similarly, underneath the horizontal axis, You can see the surgical outcomes. These are rated as completely cured, much better, slightly better, unchanged or worse in patients with Boston Carpal Tunnel Questionnaire symptom severity scores ranging from less than 2 to 4 to 5. And again, how bad it feels to the patient is a very poor predictor of how they will do with surgery. So, what does make a good measure of severity? This is what I think. First of all, it should be objective. Nerve conduction studies certainly fit that criteria because it's a nice numerical measurement. It should be validated against other indicators. We should know that it means something. So here, for example, we've got the cross-section of the median nerve on an ultrasound scan in 1100 odd right hands at first presentation with carpal tunnel syndrome. And the size of the nerve is up the vertical axis, and the nerve conduction grade from 0, normal, to 6, the most severe, across the horizontal axis. And you can see that there's a fairly clear relationship between an anatomical measure and a physiological measure. So there is clearly some validation there. In terms of measurement scales, we would all like ratio scales for everything, but we're probably not going to get a ratio scale for carpal tunnel syndrome. What we can do, however, is look at the subjective severity on the vertical axis here against the physiological severity on the horizontal axis. And we see that there is actually a relationship between the severity of symptoms and the severity of the physiology. Not only that, it's an almost linear increase in symptom severity from the mildest to the most severe. The problem with this relationship, and you'll have seen papers elsewhere which say there is no relationship between symptom severity and nerve conduction studies, is that the R value for this correlation is distinctly poor. This is 0.26. And although this relationship is enormously statistically significant, that's because there are 27,000 patients in this graph. The individual variation on each of these is very wide indeed, and knowing the measurement on one of these scales in an individual patient is of absolutely no use whatsoever in predicting where they will fall on the other scale. But it is, when you look at a large number of patients, a relatively linear line, and the ordering is exactly the same. So we have good evidence here that grade 2 really is, on average, worse than grade 1, and grade 3 is worse than grade 2, and grade 4 is worse than grade 2, and this scale does actually make a linear kind of sense. Fourthly, our measurement should be sensitive to change. So here, I've given you the change in nerve conduction grade with surgery on the horizontal axis. So those that were unchanged are in this block here, and people who got better are this way. This is 1 grade better after surgery, 2 grades better, 3 grades, 4 grades better. And this is all of the people who were actually worse after surgery. And the bars are the proportions of those patients who said that they were successful operations and unsuccessful operations. And again, you can see a very clear relationship between the fact that patients whose nerve conduction studies were worse did indeed feel that they were worse, and conversely, as the degree of improvement in nerve conduction gets better, we have better and better results from surgery. So these things do change with surgery, and we'll see that in another graph later. They should ideally be predictive of the response to treatment. So this is a graph that I've published on several occasions in different forms. There will be yet another new version once we get to about 10,000 operations. At this point, this is 9,130 operations. And we ask patients very specifically not to say, are you satisfied with how you were treated, but did you achieve the relief of symptoms that you wanted when you went into surgery? And it's a very simple scale. They're either completely cured, much improved, such that any residual symptoms are no longer a nuisance, better, but still a nuisance, the same, or worse, and I wish I'd never had it done. And this is a non-linear relationship. You get the best results from surgery if you treat them in the middle grades. As you go towards the most severe end of the scale, the success rate drops off to about 50%. And if you treat people with normal nerve conduction studies, even if you're fairly convinced they've got CTS, the results are not that great. I think this is probably partly misdiagnosis, and partly people with dual pathology have actually got something else contributing more to the symptoms than was first realized. But there is a definite predictive element to this. The suitable severity scale should also be uniform. It should be the same in different settings and laboratories. And the 0 to 6 scale that we are talking about here was rather carefully devised in such a way that a report from 2 laboratories with different normal ranges, seeing the same patient, would usually come out with the same grade. That's now been adopted across the UK as a standard. And finally, it should be comprehensible. I think we established with the first question early on that most people outside neurophysiology do not feel entirely happy interpreting the tables and numbers and squiggly lines. But I think we can all comprehend a scale from 0 to 6, both doctors and patients. So that's what I think makes a good severity scale. And it leads to this proposal for how you should treat patients, all other things being equal. If they have negative nerve conduction studies, but a suggestive history, they've probably got carpal tunnel syndrome, but they're not in any immediate need of rescue surgery. You can afford to try the other things, you can check other tests, you can try an injection. The grade 1 and 2 cases are still on the uphill slope of that graph. So you can afford to treat these people conservatively, and if, as in the case of one lady who I've met who had her carpal tunnel injected in 1960 and survived until 2008 when it recurred, you get a response like that, you've hit the jackpot really. The ones on the downhill slope, the grades 4s and 5s, should probably be encouraged towards surgery. And the ones in the middle can do what they like. A special mention for grade 6, however, bear in mind that 50% success rate. You need to manage the expectations of these patients. Patients who wish to try an injection to do beforehand can do with very little risk, but most of my grade 6 patients do eventually go for surgery. Next scenario, failed carpal tunnel decompression. This really covers 2 categories of patients. I was talking in the summer at an event where this was described as recurrent versus recalcitrant CTS. I don't really like the term recalcitrant. It sounds as though we're trying to blame the failure of surgery on the CTS or the patient rather than our failure to fix it. But really, this is about primary failure to relieve the symptoms, as opposed to the patient who gets better and then gets the same problem again later. They're very different scenarios. Again, we have a surgeon making a blanket statement that the nerve conduction studies are useless in this situation. This is David Ring. To understand his difficulty with this, we have to look again at how the nerve conduction studies change with surgery. So this is the change in grade. So same grade as before surgery, an improvement in grading after surgery, and a deterioration in grading after surgery. And here I've given the mean opinion of the patients as to whether this was successful or not. So you can see the patients who feel that they are cured or much better are essentially those who've got a 2-grade or more improvement in nerve conduction studies. It doesn't matter whether you started at grade 6 and improved to grade 4 or started at grade 2 and improved to normal. Those groups of patients are equally satisfied with the results of surgery. So this is the situation Professor Ring finds himself in when faced with a patient who's not happy with the results of surgery. Down the left-hand side, we've broadly got the possible reasons for failure. The commonest of these in most studies is incomplete release. And this is particularly important to recognize because these diagnoses, highlighted in yellow, have immediate implications for decision-making. These problems are potentially fixable with further surgery. In the middle column, we can see that the symptoms don't really help us to differentiate between the first three. At the right, we can see the range of possible post-operative nerve conduction results in each situation. And this is all Professor Ring has, because he's decided he can dispense with the preoperative results. The nerve conduction studies are indeed not as helpful as they could be. At least if they're normal, that makes it unlikely that there's been an incomplete release, but the range of findings overlaps extensively with what would be found when the ligament has been released and where re-exploration of the carpal tunnel is not the right thing to do. For completeness, I've also put in a line here for recurrent CTS at the bottom to point out these cases, which are clinically distinct, as we pointed out earlier, can have virtually any nerve conduction grade. The diagnosis of recurrence rests on the same clinical interpretations of symptoms as the initial diagnosis of CTS, supplemented if necessary by evidence of deteriorating nerve conduction, but this of course requires serial studies. Now let's employ a time machine and go back and do the preoperative studies. Now we can replace just the post-operative studies with the likely range of changes in nerve conduction results in each scenario. Now the problems which require early surgical intervention stand out like the proverbial sore thumb, and the only real uncertainty concerns the question of whether the nerve might have been so far gone before operation that it was never going to recover, grade 6. In such cases, the nerve conduction studies generally do not change, but you can recognize them from the preoperative nerve conduction studies. If it was grade 6 before and after surgery and the symptoms haven't changed, then it's very unlikely to respond to repeat decompression. So here is a flowchart algorithm for how to deal with failed carpal tunnel decompression. If you don't have the preoperative studies, you're highly likely to end up here. And the only thing that will rescue you from your diagnostic uncertainty at that point is probably a good ultrasound scan. If, on the other hand, you've got the pre and post-operative studies, you will probably end up in one of these square boxes with a fair idea of what's going on. That's more than enough about carpal tunnel syndrome. So let's have a little word about ulnar neuropathy. And here's one more barcode for you to have a crack at. How many different sites of pathology are there for an ulnar nerve region in the an ulnar nerve lesion in the region of the elbow? This is the perfect audience to ask this question. "17 responses at this point. I suspect a few people have fallen asleep by now. So you can tell this is a hand surgery audience because we've got lots of people going for quite high numbers. We've got 5 people who think there are more than 5 sites of entrapment around the elbow. 5 people who think there are 3. And only 1 person going for 2 and 1 for 1, which is quite interesting. So I got this picture from an orthopedic website, and this bunch claim there are 9 distinct syndromes around the elbow, which I think is a bit of overkill. So I've been talking for quite a long time with a chap called Simon Podnar. He was a neurophysiologist in Ljubljana, and his co-workers. And he reckons the vast majority of ulnar nerve lesions at the elbow fall into only two categories. So the audience can argue with me about this afterwards, I think. The majority in his practice are in the retrocondylar groove, and they are seen in the non-dominant arm of people with essentially desk jobs. They're younger on the whole, and this is not an entrapment syndrome. This is chronic external trauma to the nerve. Too much time with the elbow bent and leaning on the edge of the desk and a chair arm. The smaller group are a little more distal, just underneath FCU. And these he tends to see in manual workers, the dominant arm, and that really is an entrapment. And he was able to divide almost all of his patients into those two groups. The other things that are written up as case reports are almost vanishingly rare. And they can be localized quite accurately using very short segment nerve conduction studies along the nerve, and they have distinct appearances on the ultrasound imaging. There is probably some prognostic value in testing ulnar nerve problems. However, I have to admit that we don't actually have much in the way of good therapeutic options for this. I'm sure you'll all accept that ulnar nerve surgery is not as satisfying to carry out as carpal tunnel surgery. Quite a lot of these patients are unchanged, but there is some prognostic value. This is work from the Netherlands. They found, quite interestingly, that the ultrasound was quite a good predictor of patients who would not get fully better. So anybody with a nerve diameter of over 3.5 millimeters at the elbow always had residual symptoms, regardless of whether they were treated conservatively or surgically. And the Dutch have built this up into a multivariate prognostic algorithm. There we go, which is scored like this. You need the MRC score for ADM. You need some nerve conduction results, and you need the ultrasound, and you score it, and you have a prediction of successful outcome to surgery here. This was published about 4 or 5 years ago, and I don't think anybody has tested or replicated it yet. And I would love to see a series published prospectively with people scored on this algorithm and the outcomes tracked for ulnar nerve surgery, as it badly needs replicating. So these are the final take-home measures. First of all, in nerve injuries, the timing of the investigation is absolutely critical. Please cooperate with us in trying to organise it. Tell us on the request form or ring us up and talk to us about when the injury was, and we will generally try and schedule testing to be as useful as possible, provided we know about it earlier. And then in subacute and chronic nerve injuries, I hope I've convinced you that you should be using this not as a diagnostic test, but as a quantitative measure of nerve dysfunction. Just another tool in assessing how bad your patient's problem is. And with that, I'm going hoarse and we're going to stop. So